Hi, good morning all. Myself, Dr. Nelby George Mathew, consultant neonatologist at Jubilee Hospital. First of all, I would like to thank NNF India for giving me an opportunity to be here with you. Over the next 20 to 30 minutes, we will discuss certain aspects regarding prevention of infection in NICU, a very important topic to anyone who is working in NICU. So the first and the foremost question is, why should we discuss so much about prevention of infection in this platform? If you see this chart, almost 20% of the neonatal death is directly attributed to neonatal sepsis, and almost 43% of the babies die because they are born premature. So anyone who has worked in NICU knows that most of the preterm babies die because of sepsis. So if you take these two together, almost 50% of neonatal death can be attributed to neonatal sepsis, either directly or indirectly. More importantly, it is a preventable cause of neonatal death. That is, the most common cause of preventable neonatal death is neonatal sepsis. In the current scenario, this has got more significance because more preterm babies are surviving, which leads to the prolonged NICU stay for them. Thereby they are more prone to acquire microorganisms from the NICU environment. More importantly, premature infants have an underdeveloped immune system. As well as we all know, there's a lot of invasive procedures we used to do in these preterm babies, inviting infection. This all makes this subgroup of population more prone for infection. So prevention of infection is much more important than cure because it is much easier than the cure. Moreover, even if you cure a baby with sepsis, that will have long-term effect. That sepsis will have long-term effect on the brain, developing brain, leaving behind sequelae to the babies. So literally we should have zero tolerance to hospital-acquired infections. Certain things should never happen in an ICU. That is, there should be a big no to certain things like hypoglycemic brain injury, missed hypothyroidism, unattended deliveries, hypobilirubinemia leading to kernicterus. Likewise, hospital acquired infection should also never happen in an ICU. But sadly, our attitude is little bit our attitude is not that aggressive against hospital acquired infection. We tend to think, oh, it's a preterm baby, so he's prone for infection. What is the big deal in having a hospital acquired infection? That attitude should change. That is the first thing for the prevention of infection is the attitude of the healthcare workers in the NICU against hospital acquired infection. So somehow we have to break the chain of infection. For breaking the chain of infection, there are certain steps. There are ideally 6 steps for preventing the breaking the step of infection. First, we have to prevent the entry of microorganism into the NICU. Then we have to prevent the proliferation of microorganisms in the NICU. Steps should be taken to prevent the baby to baby spread of infection. Steps to be taken to decrease the entry of microorganism into the baby. We have to decrease the susceptibility of the baby, and for all this we need a better administrative practices. So we'll see each step one by one. So the first step is the prevention of entry of microorganism into the NICU. For that, we have to make sure that the baby is delivered in a clean area and the resuscitation is done in a clean way. So to make an NICU infection free, the baby has to be delivered in, we have to start right from the labor room. Baby has to be delivered in a clean area, to resuscitation in a clean manner. We all are well familiar with the 6 cleans of delivery. We have to meticulously practice it and make sure anyone who enters the NICU, hand washing is meticulously done, following all the steps of hand washing. We all live in a world where we cannot live without a mobile phone. Is the mobile phones allowed in the NICU? We tend not to clean the mobile phone properly, so it can be a source of infection, and so ideally mobile phone should not be allowed in the NICU. The NICU location is very important. It should not be near the septic labor room or the any other intensive care unit should not be there near the NICU. And traffic to other areas should not be through the NICU. We have to make sure that this is the most important area for the prevention of inf- infection in the NICU. Wash basin should be there at the NICU and right, and a continuous source of non-contaminated water source should be there, and everyone should be promoted to properly wash the hand before entering the NICU and make sure the water is non-contaminated. Work with your HIC team in between, see whether the water is non-contaminated or not, proper chlorination is done or not, because sometimes this water itself can act as a source of infection, like this Elizabeth Kinkia infection. Everything can is waterborne infection. So we have to make sure that the water is clean and the water source should be continuous. Water supply should be there. Second step is the prevention of proliferation of microorganisms. This picture I have taken from adult NICU, but the basic principle remains the same. There are certain areas in the NICU which are common areas for all that access the source of infection for multiple babies, like the computer, the door handles. These things has to be specifically cleaned during the cleaning session, and anyone who's using the common area has to do a hand rub before and after using these common areas or before touching the baby or baby surroundings. What we have done in our NICU is we have kept a hand rub near the computer area. So anyone who is using the computer or the land phone has to do a hand rub before touching the common area. These small steps can help in decreasing the rate of infection or proliferation of microorganisms. The NICU should be spacious and it should not be very congested. Step 3 is the prevention of baby to baby spread, of which the most important thing is hand hygiene. So, if you ask me what is the most important step in preventing infection in the NICU, it is the hand hygiene. So, literally, the whether your baby should go home safely or not depends. It is there in your hand. So a clean hand helps the babies to go home safely. So you have to meticulous. There should not be any compromise in hand washing. So your hand washing should be so robust that even if there is infection or microorganisms in the environment, in the NICU, it should not reach the baby because your hand washing should kill them. So at least if you are washing the hand, at least it should be 40 to 60 seconds following all the steps of hand washing. So if you take if you see that statistics of HIC in any hospital, most probably the NICU will be ranked the first. But the question is, if you do an internal audit, taking into account each steps, you can find that the compliance of hand washing is poor. That is, everyone used to wash their hand, but sticking on to the steps of hand washing is not absolutely fine. Similar is the case for hand rub. It should take at least 20 to 30 seconds, and you should take at least 3 ml of hand rub. That hand rub is usually 60 to 90% alcohol with chlorhexidine. And you have to do the 6 core steps of hand hygiene. Then only you will be able to properly prevent the infection. The next question is, when should you do hand hygiene? I'm pretty sure that everyone is well versed with the 5 moments of hand hygiene. So the step which everyone is lacking is after touching the patient surrounding. We usually tend to do hand hygiene before touching the patient, after touching the patient, before aseptic precaution. But just think back. Do you used to do hand hygiene after after switching off this alarm button of a pulse oximeter or after changing the ventilator parameters? We tend to forget it. So make sure that even after touching the patient's surroundings, you have to do hand hygiene. So there should not be any compromise whenever there is a decrease in the hand hygiene. The most common quoted excuse is time constraint. It was busy, so we couldn't do hand washing, hand hygiene. But I feel it is not the time constraint which is the major obstacle for hand hygiene. It is the attitude of the healthcare workers because the hand using the hand rub takes only 20 to 30 seconds and adequate hand washing will take only 60 seconds. So it is not the time constraint but the attitude which makes the difference. And the average time taken usually adapted for by a healthcare worker is found to be less than 10 seconds. So we have to improve in our hand washing, no doubt about it. So we'll see certain practical aspects to improve the hand hygiene. We all have a false belief that if you put gloves, everything is fine. No, gloves does not replace hand washing. Then even if you are putting sterile gloves, you have to properly wash the hand before doing it. Then, if you see this hand, it's actually outside the NICU, it's really a beautiful hand. But inside the NICU, this hand is a typical source of infection. You have to remove the watch, you have to remove the jewelry, you have to cut short the nails, and you have to remove the nail polish. So, a most beautiful hand in an ICU is the one having a natural nails which is cut short. And if you have any cuts or abrasions, cover it with waterproof dressing. And ideally, you should monitor the hand hygiene and provide performance feedback. There should be a mutual monitoring system. Anyone can point out anyone. The staff or the junior doctor can point to the consultant or anyone that you have not done the hand washing. Please do it. Then there should not be any ego. Then only our hand hygiene will improve. Actually, in the NICU, the baby is the most important person. So we have to keep our ego, everything aside and do the best for the baby. And also we have to some sort of monitoring system should be there. What we used to do is we used to see how many bottles of hand rub we have used every week to just have a basic idea how much hand hygiene is going on. Is there any decrease in hand hygiene? This type of monitoring system will help us to improve ourselves. Place reminders about the importance of hand hygiene in the NICU. So you have to keep on reminding yourself, I had to wash the hand, I had to wash the hand. Place alcohol based hand rubs near the baby. If you see this, this hand rub is placed here. Now, no one is going to take care. It should be easily accessible to the healthcare workers so that we can use it quite regularly. And what another thing what you can do is keep a hand rub with yourself so that you can intermittently use it. Another issue is once you start meticulously doing the hand rub, you will get some of the stuff will get irritation and because of the drying of the hand, and it is really painful again to put hand rub into it. Then the compliance with the hand hygiene comes down. So you have to avoid this. The best thing is outside the NICU, apply proper emollients to make it to prevent the dryness. And inside the NICU, what you have to do is don't immediately wash the hand before or after applying the alcohol rub. And don't put on the gloves when your hands are wet. These things will help to decrease the irritation. So I have told a lot of things about hand hygiene. I'm pretty sure that hearing this, some of you may have think. So I don't want to be an issue staff because there is too much hand wash is there. No, basically that has to come as an obsessive compulsive disorder to you to decrease the incidence of infection in the anatomy. So we have discussed what all things we have to do to prevent the entry of microorganism into the NICU. Secondly, we discussed how can we prevent proliferation of microorganism in the NICU. Third thing we discussed was how to prevent spread of infection from one baby to the another baby. And nextly, we will be discussing right now how to prevent the entry of microorganism into the baby. So for the baby, the most important protective thing is the skin. So, unluckily, the newborn skin, especially the preterm baby skin, is very fragile. The epidermis and the dermis is not thickly adhered, so there is chance of epidermis being easily torn off. The issue is not the skin injury itself, but it acts as a portal of entry to the microorganism, thereby leading on to sepsis. So we have to be very careful regarding how to take care of the skin. There should be a unit protocol regarding the skin care. And small things can change the difference. So suppose you are taking blood from the baby, the usual practice is put the cotton there, put a bandage. While you are removing the bandage, you are actually injuring the skin, acting, giving a portal for entry to the microorganism. What you can do is just press there for some time and see whether the blood is coming or not. Then take off the plaster rather than applying or take off the cotton rather than applying a plaster. That 1 or 2 minutes may change the course of course of stay of the baby in the NICU. These small steps can prevent the infection in the NICU. So you have to be very careful while applying the plasters. A minimum size plaster should be applied. Even if you are applying, then while applying adhesive for ET fixation, the minimal adhesive and easily removable adhesive should be applied. While removing the adhesive, utmost care should be given not to injure the skin. Next, there are certain bundles which helps to prevent infection. Right from IV cannula care to central line insertion, there should be a written protocol how to put it, and each step aseptic precautions has to be maintained. More than the time of insertion, maintenance of central line as well as the peripheral line has to be on a protocol based approach. Like for example, the practice should be there should be at least 15 seconds scrubbing should be there in the hub side, and then once and there is bundle approach for everything. The VAP bundle, that is ventilation associated pneumonia prevention bundle. The tube should be kept in such a way that it should be in sleeping position so that the secretions won't go to the ET tube. Secondly, routine suctioning should not be there. Not introduce saline into the ET tube. These steps can help in preventing the ventilated associated pneumonia. Then, of course, if in Indian scenario, anything which is invasive, we are inviting infection. So, what you should do in everyday rounds, right from IV cannula, just think whether it is needed or not. If not needed, take it out. For that, you have to introduce feeds at the earliest and grade up feeds in a faster manner, in a faster way, so that IV cannula we can remove the cannula at the earliest. Everyday rounds, you should think whether the central line is needed or not. Each day of central line, you are inviting infection. So remove it. Next thing is ventilation. Keep the ET tube in position only if it is absolutely necessary. Move on to non-invasive ventilation. We have a beautiful, luckily we have beautiful modes of non-invasive ventilation like CPAP. At the earliest, move on to non-invasive mode of ventilation. This all helps to prevent the entry of microorganisms into the baby. So these things I have discussed how to prevent infection from the skin flora. Next thing is medical adhesive related skin injury. This I have discussed. Mechanical skin injury should be minimized as far as possible. Epidermis is easily separated from the dermis in newborn babies. So utmost care has to be taken while taking care of this baby. Another very important source of infection, portal of entry is injury following the CPAP. We should minimize it. Everyone used to ask whether the CPAP mask or prongs, which is more dangerous, which causes more injury. Actually, the site of injury is different for both. So actually rotating these mask and prongs on regular basis helps to decrease the incidence of injury. More important is regular monitoring for the sites of injury. And if there is redness, remove the mask. If while applying mask, remove the mask, put on the prongs and see for injury. This applies not only to CPAP, even for IV cannula. Routine surveillance is very important. If there is redness, remove the cannula. Now, the fifth point, the next point is decreasing the susceptibility of the baby for infection. Actually, if you see the antibiotic, it is a double-edged weapon. For sick babies, antibiotic is definitely indicated. But the problem with rampant use of antibiotic is it kills the normal microbiota also, which helps the pathological microbiota to overgrow. So what you can do is, even if you are starting an antibiotic, see if by day 3, if the baby is well, sepsis screen is negative, culture is negative, stop the antibiotic. There is no need to continue the antibiotic for 5 days. Another clinical scenario is if the baby was really sick, you have started 2 antibiotic and the susceptibility comes that the baby is sensitive to both. Stop the higher antibiotic or the antibiotic with broader spectrum. Treat the baby with narrow spectrum antibiotic. This is for the prevention of resistance development in your NI. So other things what we can do to reduce the susceptibility of the babies to infection is allow both the parents to enter the NICU, but supervise them, guide them what all regarding proper hand washing techniques. And more importantly, mother should spend maximum time in the NICU. That is, you have to maximize kangaroo mother care. Start KMC at the earliest, immediately after the baby is stabilized. There is a concept called enteromammary reflex. Suppose your NICU is having Klebsiella. Once the baby, this what happens is this poor baby may not be able to mount an immune response against this infection. But once the mother comes in, this mother also gets the same pathogen. That is, if it's Klebsiella, the mother also is getting Klebsiella. She will mount an immune response against the organism, and this antibody will be secreted through the milk, and that baby will be getting it, and that acts as a barrier in the intestine for the organism to come to enter the bloodstream, thereby helps in preventing late onset sepsis. So maximizing KMC will decrease the susceptibility of the baby to infection. The next thing is early feed. Early feed has definitely found that to increase the incidence of infection, especially the mother's own milk. It decreases the incidence of NEC by almost, if you give a mother's own milk early in for preterm baby, if you are giving 10 babies mother's own milk, you are preventing one NEC. That it's very important thing. So you mothers should be motivated to express the breast milk for preterm baby at the earliest, and you should start mother's own milk at the earliest. Reinforce the importance of colostrum. Colostrum should be considered as the first vaccine. More than the nutritional value, it has got immunological value. So, whatever the reason, don't curtail the use of colostrum. Even if the baby is kept in pure, apply the colostrum on the mouth. This helps us to increase the immunity and decrease the susceptibility of the baby to infection. Antibiotic stewardship we have already discussed. Another novel concept is mother NICU, which is coming up, where the mother is in the NICU with the baby, not for stable babies. For sick baby also, the mother is in the NICU with the baby. I'm pretty sure that in 10 years' time, most of the centers will be starting mother NICU, which will definitely decrease the incidence of infection in NICU, especially the cross infections. So, coming to the basic requirements of asepsis management things, there should be enough space, there should be regular running, safe running water, elbow operated taps should be there, avoid overcrowding, and very important thing, there should be enough adequate staff. The staff baby ratio should be maintained. Then another thing is a very important topic is housekeeping and aseptic routines. My friend Julian will be talking about this housekeeping and aseptic precaution in detail in the next slide. So thank you for patient hearing. So if you ask me one take home message, what I had to say is the way whether your baby should go home safely or not, it depends. It is there in your hand. So don't compromise on the hand hygiene. All healthcare workers in working in NICU should develop an OCD for hand hygiene. Thank you all.